In this video, we shall be discussing a very important topic, which is your biliary injury. So, we have a classification to classify the various bile duct injuries which occurs during your laparoscopic cholecystectomy, which is known as your Strasbourg classification. So, in Strasbourg classification, we have your A. So, over here what happens in A is, it is injury to your small ducts which are in continuity with the biliary system, with your biliary system associated with your cystic duct leak. Now, type B is where you have injury to your sectoral duct with consequent obstruction. Now, type C is your injury to your sectoral duct with consequent bile leak, and if you see in your type D, it is your lateral injury to your extra hepatic duct. Right. Now, your E is further classified. This is your Bismuth classification. Right. So, if you see your E1, so your E1 is when your stricture is basically more than 2 centimeter distal to the bifurcation, right. Now, in case of E2, it is your less than 2 centimeter distal to bifurcation. Now, in case of E3, you have your stricture at bifurcation. Now, in case of E4, you have your structure involving the right and the left hepatic duct, but not in continuity, right. So, this is a stricture involving your right and your left bile duct, but not in continuity. Now, in your E5, you have your complete occlusion of bile duct, right. So, this is your Strasbourg and your subclassification of your Bismuth. So, now what are your goals of therapy in your biliary injury? So, first is your control of infection and limiting your inflammation. So, how do we achieve that? With help of IV antibiotics and your percutaneous drainage. Then we have your second important goal, which is your clear or thorough delineation of your entire biliary anatomy. Now, this is achieved with the help of a magnetic resonance cholangiopancreatography or percutaneous transhepatic cholangiography, or with the help of ERCP. Then we have your third goal, which is the re-establishing of your biliary enteric continuity. Now, this is achieved with the help of a tension-free mucosa to mucosa repair. Then we can do a Roux-en-Y hepatico-jejunostomy, and your third is the use of your trans-anastomotic stents, right. So, now let us look at the approach to manage your bile leak. So, first we check the status of the patient. Now, if the patient is stable, then we check for the drain output, right. Now, if the drain output is less than 200 ml, we go for a conservative management. If it is an intermediate output, that is between 200 to 500 ml, we go for a supportive care plus minus use of stenting. Now, if it is a high output more than 500 ml, then we go for a ERCP plus supportive care. Now, if in this stable patient you do not have a drain, then we put a drain under USG guidance. Now, following this, we review the patient after 6 weeks with the MRCP or ERCP. Now, if the leak persists then we need to plan the patient for your Roux-en-Y hepaticojejunostomy, and if the leak seals, then we just follow up the patient. Now, what if your patient was your unstable? Now then we check whether there is drain in situ or not. If there is drain in situ, then we go for a functional assessment of the drain. Now, if it is functional, then we go for a conservative management and manage the cholangitis if the patient suffers from it. Now, if the drain is not present, then what we do is we go for a USG guided percutaneous drainage. Now, following this, we observe the patient, and if the patient further deteriorates, then we plan the patient for your exploratory laparotomy, where we would be basically placing the drains, and if the condition of the patient permits, then the definitive operation may be done under the same setting, but usually in such unstable patients you would just place the drains and do a peritoneal lavage and come out, right. So, this is with respect to your bile leak management, right. Thank you.